one of the things that I think is a great visual to understand, if you did have a vaginal delivery, this is something that one of my mentors, Lynn Schulte, taught us at the Institute of Birth Healing, that our pelvic bones move in a predictable pattern during a vaginal delivery. So we can use that pattern of bone movement to reverse engineer and correct what we see postpartum. Okay? Because our pelvic floor muscles attach to these three bones and they create like a hammock. So if this is upright, tailbone, pubic bone, sit bones, our pelvic floor is the hammock at the bottom. Okay? The muscles are holding on to the bones. They're attached.
Okay.
For a baby to come out, first they have to come into our pelvis, this space here. So they have to come in here. The bones move like this. Can I show you with the baby? Are you okay?
Yeah, please. It's a little bit like, whoa.
I know vaginal deliveries was not your thing, so you let me know.
Yeah, you do it.
So
you do it. Show us.
Typically, the babies come into the pelvis looking to the side. So that's what the head shape is, to the side. So they come into the pelvis here. And it helps when the bones move. The iliums come out and the sacrum comes under. The tailbone tucks under, okay? See how that widens the space where the head can go in? Whereas if the sacrum is lined up and the pelvic bones are lined up, that's a tight space. You see that? Okay, so it's about the head position. So we work with our moms to allow this pelvic inlet to open up. Then when the baby comes out, the pelvic outlet has to open up. So the baby's already in. Typically, hopefully, they look face down because that's easier, the easiest position, though we can really birth babies in quite a number of positions. Then the pelvic floor muscles have to stretch maximally to open this space and let the baby come out.
Got it.
Okay? Typically head first and then the shoulders. Whoop, then
and when their babies are standing up or bottom first.
Bottom first, feet first, yeah. That's a whole thing. A whole thing. Yes. The main message with that
sounds so painful.
I mean, it can be, but it's pretty phenomenal that these bones can move as much as they do. And truthfully, I mean, they don't need to move this much. It's millimeters what we're checking for. Typically, we get them either face up, the moms face up or face down, and we're able to mobilize through here and get this sacrum to be flexible in all planes during their pregnancy so that there should be no bony blockage to that baby coming into the pelvis and out. Does that make sense?
That makes total sense.
And not only do we mobilize the bones, but then we release the soft tissue, glutes, low back, inner thighs, outer thigh. Like, we do really effective massage and myofascial techniques to make sure that the muscles don't just pull the bones right back to where they were, right? Because we know the body has habits, postures,
memory,
tendencies. Yeah, memory. So if we don't intervene after we mobilize the bones, we massage, we stretch, and we strengthen. So it's like all roads are leading to this pelvis being able to move. Okay? So back to incontinence.
Yeah, I was like, what does this has to do with leaking?
Yeah.
I mean, it has everything to do, but I'm like, okay, the baby's out. Now I'm peeing everywhere.
The baby's out, now I'm peeing everywhere. So it could be a consequence of having trauma, or even simply, like you could say, a tear to the pelvic floor muscles. So the most common place to tear, though we can tear anywhere, is the perineal body. That's the space between the vaginal opening and the rectum. Okay? I have a really great model. Okay, so these are vulvar models, which most people would want to say this is a vagina, but the face of the vagina is a vulva. And so typically we tear down here. And so that is the common tendon for many pelvic floor muscles. So you get a tear here, you have quite a few muscle groups that are now impaired. One of the functions of your first layer of pelvic floor is sphincteric. That's a circular muscle, and it closes from an open circle to a closed circle. That's like the, in a pipe, that's like the
opening valve and
a valve, a valve to a pipe, thank you. So you cinch that when you're trying to not urinate. So it's not like, that's an easy one to understand, right? If you have a tear in a sphincteric muscle, it can no longer close at the bottom of a tube and liquid flows out,
Yeah.
right? The other common contributor to not being able to keep urine in is if you have too much pressure inside the abdominal cavity. It's again a factor of weakness, but if we have this distended abdomen that's kind of swollen, we're bleeding anywhere from a week to 4 or 5 weeks postpartum, the uterus is coming back to a smaller size, there's a lot going on intra-abdominally. So if we have pressure from that, if we have bloat from eating on the go, if we're full of fecal matter because we don't have time to sit and empty our bowels, or we're suffering from incontinence, inactivity, poor diet can contribute to constipation. So any of those factors that will make the inside of your belly feel heavy, swollen, or bloated. You're adding weight to what the pelvic floor muscles have to do to keep stuff inside.
And they're weak.
And you're weak. Yeah. I mean, you don't have to be, but typically we are.